Hello, everybody, and thank you for coming. This session is going to be focusing on acute myeloid leukemia. Title is Opportunity Knocks in Acute Myeloid Leukemia, and we're looking forward to sharing some of the updates in acute myeloid leukemia, as well as hopefully have some time for discussion. The panelists today are my friend and colleague, Dr. Tapan Kadia, and myself, Naval Davar. We're both physicians at MD Anderson who focus on acute myeloid leukemia. We'd like to thank the Medical Learning Institute and PeerView for providing the session, as well as to our sponsors, AbbVie, Actinium Pharmaceuticals, Astellas, Daiichi Sankyo, Janssen, Cura Oncology, and Syndax, all of them for providing educational grants for this symposium. So if you haven't already, please do complete the pre-event survey, and that will be very helpful to us, especially if you can also then do the post-event survey, and look out for any additional polling questions that will be during the presentation. And then if you have any questions, the room is very big, so I think it's going to be hard to move the mic around, so just put them in through the app. That will be the best way, and if not, then we'll find a way to get them answered through the mic. So this is important. If you are able to scan the QR code with your personal device, this will help you both answer the polling questions and as well as ask questions to us as the faculty. So I would recommend to go ahead and do this. You can do this through your camera app. You focus the camera onto the QR code. It should capture it. Then you can click the link and it should open. So I'm going to give everybody a few seconds here so they're able to get that set up. All right. So this is the website where you can actually get access to all the slides, and eventually, my understanding is the full recording also will be available after a few weeks, as well as on Twitter. If you'd like, you can join the conversation or follow or retweet through the @peerview.link. So for a initial question, we're going to try to get an idea about the practice of the people in the room. So as well as what they would like to hear about. So based on the options you have, what do you think represents a challenge or question in modern management of AML? And you can select more than one. So you may think there are many challenges in AML. I do think so. So choose whichever ones you think are challenges. So deciding who's a candidate for intensive or non-intensive venetoclax regimens, when FLT3 inhibitor chemo induction or chemo-free FLT3 triplet is appropriate between these two, how do you choose? Choosing a maintenance option in FLT3 mutated acute myeloid leukemia, and then important and exciting new options for challenging relapse refractory AML, such as patients with KMT2A or NPM1. So which of these are ones that you have questions or would like to learn more about? You can choose those. Okay. Okay, so as expected, all of these seem to be very relevant points of discussion in which there are many questions, and I will say today we don't have the answers to all of them, but these are all being looked at actively in various clinical trials or ongoing analyses, and we're going to try to give you some of the data here, which may not be conclusive or definitive yet, but hopefully will eventually in the next couple of years lead to more clear recommendations. Next slide, please. Okay. So just kind of an introduction. Many of you here, I'm sure, must be familiar with the changes in the acute myeloid leukemia landscape. For those of you who are not, there has been a tremendous slew of approvals in acute myeloid leukemia in the last 7 years. So from 2017 to today, we've actually had a total of 11 drug approvals. These include multiple targeted therapies, actually 3 FLT3 inhibitors, 3 IDH inhibitors, BCL2 inhibitor venetoclax, which is a very crucial component of various combinations, oral azacitidine, as well as new formulations of chemotherapy such as CPX-351, and maintenance options such as the oral azacitidine and gemtuzumab, which is an antibody drug conjugate. So definitely compared to, let's say, even the last 50 years, we've had more drug approvals in the last 6-7 years. So we are seeing progress. However, at the end of the day, the long-term survival of AML still remains below 40-50%. So there's still a lot of work to be done to use these drugs in the right combinations in the right sequence, as well as understanding better how to use MRD for selection of particular therapies and transplant, as we do, for example, in acute lymphoblastic leukemia, quite effectively. This is one of the reviews that we published a couple of years ago, and I think in general is still quite applicable. So when you look at AML patients, there's not kind of one homogeneous treatment. It is definitely no longer 7+3, and if not, palliative options such as best supportive care, Hydrea, or cytarabine. That is not how the current landscape is. That is how things were actually just 10 years ago. So now we have much more targeted and...
Welcome, everyone. Thank you for joining us for today's program.
Oh.
We're glad you're here. Please take a moment.
We're going to start again. I'm just kidding. So there's a voice above us that controls everything. But anyway, so we have many different focused options. So for patients who have core binding factor, we add gemtuzumab. This is very, very effective in improving outcomes in patients with inversion 16821. FLT3 mutated for sure should get a FLT3 inhibitor. We're going to talk about that more in detail. And then for a secondary therapy-related AML, CPX351 has shown survival benefit and can be considered. And even for the others who may not have one of these specific subsets, addition of agents such as venetoclax are showing improvement through CLIA venetoclax, FLAG-IDA venetoclax. And similarly for older AML, we're looking at improving on the HMA-ven by incorporating targeted therapies, whether these are in combination, sequences, MRD-directed. That is something that current trials will help guide us. I think the biggest unmet need today remains TP53. There's really nothing that we can claim today that has moved the needle. There are a lot of immunotherapy and other agents being investigated, but I think this space still is going to take a few years of effort before we can have breakthroughs, but we will, hopefully, in the near future. So despite all of this work, we still see that there is a nihilism in acute myeloid leukemia, which has not yet fully changed as it has in ALL or CML, where almost every patient is being treated today. We still see that almost up to 35–40% of newly diagnosed AML, when you look across centers, so this includes small community centers, academic, but still almost 1/3 of patients are actually not even being offered treatment in the frontline setting. I think with the advent of venetoclax, FLT3 IDH, this really should not be the case. For most patients, there is some form of therapeutic option or not, and hopefully we will see this becoming less and less of an issue. So the goals for today are obviously reviewing some of the evidence, especially in the targeted therapy arena, FLT3, menin inhibitors. Also try to see how we can select patients most optimally for particular treatments, as well as for transplant using MRD-based data. And then, of course, discuss some of the adverse events. And again, as mentioned, MRD is going to become more and more of an interesting topic. So with that, it's my pleasure to introduce my good friend and colleague, Dr. Tapan Kadia, who's a professor and one of the world leaders in acute myeloid leukemia research. Tapan.
Thanks.
Yeah.
All right, thank you, Dr. Davar, and thank you all for coming here. For those of you with me at 6:45 a.m., I appreciate you being here at 7:45 p.m. So we're going to talk a little bit about optimizing frontline strategies using venetoclax-based combinations. So several years ago, with the advent of HMA and venetoclax, we have a brand new option for newly diagnosed patients who are older, unfit with AML, who could not receive intensive chemotherapy. We were using HMA before, maybe some other regimens, low-dose cytarabine, but with venetoclax, we've dramatically improved their response rates as well as overall survival. But in the years that we've had these drugs, we're realizing more and more that there are ways to optimize this regimen. There's something that the label says, that you need to give 28 days of venetoclax, you need to give it a certain way, but the more and more we treat in academic centers, in the community, we have come to a realization that there are optimal ways to give it. There may be additional backbones that we can use venetoclax with, and there may be ways of optimizing the dose of venetoclax, not only the length of the venetoclax, but longer and shorter, and then adding things like growth factors, antibiotics, et cetera, and choosing the right patients who are giving HMA and venetoclax. So we're going to start with a case, and I'm going to talk to my good friend Dr. Davar here. We're going to do a very quick in and out question because we want to keep this as a discussion. This is a nice small group, and we have just an hour. So think of this as a highlights of the AML session at Soho. So John is a 76-year-old man with newly diagnosed AML. He has weakness, bruising, shortness of breath, right? Performance status is still 1. He has hypertension, diabetes, and coronary artery disease. So older AML with comorbidities. He has acute myeloid leukemia. White count is 9.5, so he's not very proliferative, but he's pancytopenic. 45% peripheral blast. You see the cytogenetics there. 5q, 12p minus, but no 17p, and the mutations are listed there. ASXL1, SRSF2, TET2, but the FLT3, the RAS, and the P53 are wild type, meaning they're not mutated. So I turn to Dr. Davar. Dr. Dover, is aza-ven the next optimal approach in this patient? What do you think?
Yeah, I mean, I think for sure for this patient, I would be considering low intensity therapy. The patient is above 75, even above 70. That's kind of where we're going for most of our patients. The data with the azacitidine venetoclax or HMA venetoclax based on VLA-A suggested almost tripling the response rates as well as significantly improving overall survival, with almost 35% of patients having greater than 2 to 3 years survival, which is something we didn't have in the past. So I think for this patient, given the current situation, I think that would be a reasonable standard of care option to consider.
All right, give the man a trophy. He got the answer correct. Certainly, this is the ideal patient for HMA-ven. Older, unfit, comorbidities, doesn't have adverse karyotype. Well, he does, but doesn't have the P53 complex karyotype. Do the NGS tell us something, right? So by ELN 2022, that NGS suggests an adverse risk AML, right? ASXL1, SRSF2, these are mutations that maybe suggest an adverse risk ELN 2022. But as you'll see, the more we learn about lower intensity therapy with HMA-ven, perhaps the ELN 2022, which was actually made for intensive chemotherapy 7+3, may not apply to HMA and venetoclax. And I'll show you that in just a minute. So if venetoclax therapy is initiated, and many of you have given this in the community or in academic centers, we give a cycle, they get neutropenic, they recover, maybe they go into remission. But as you're giving subsequent cycles, 28 days of venetoclax, we often run into cytopenias. And so are there some best practices? Just a quick hit, Dr. Dover, about what kind of things we do to help us deal with the neutropenia and the infections that can happen.
Yeah, I know we're going to go over it in more detail, but I would say the three key things is, one, is do not give continuous venetoclax, and definitely not 28 days. So we're usually doing 21 days, although even less may be good. The second thing is end of cycle marrow, I think, is very critical to know that you're stopping patient once they've achieved remission or hypoplasia. And then the third thing I would say is more liberal consideration of use of growth factors once you have confirmed a remission hypoplasia in those patients. So I think those are the key things, but there are many other factors we'll discuss.
Absolutely. So this is exactly what we're thinking about. Now, this is an ideal patient. This is ideal VLA-8 patient, right? But not every patient walks in as a carbon copy of every person. Not everyone fills all the entry criteria. And so we're going to switch it up a little bit. Dr. Dover, if I gave you the same man, he's 70 years old, a little bit younger, a little bit more fit, okay? He has, by morphology, M5, monocytic AML. His white count's a little bit higher, okay, but look at the mutations, they've changed a little bit. He has now NRAS mutation, DNMT3A, SRSF2, TET2. Maybe he had a prior CMML that has now progressed to acute myelogenous leukemia. So sure, this person still would qualify for HMA venetoclax. He still has comorbidities. Certainly I could give him HMA-ven. I could give him intensive chemotherapy. But would you think of other backbones? You know, does the mutation profile, the morphology, change anything based on the data that's just been uncovered in the last couple of years?
Yeah, so I think there's a couple of concerning factors here for this patient with aza-ven treatment. One is the morphology being M5, which is what we call monocytic myelomonocytic type. And there is data now from the group in Colorado as well as our group showing that this group may respond, but the responses are short-lived, they relapse soon, and the outcome is not as good. And the second thing is the RAS mutation. The patients who have RAS mutation as well as FLT3 mutation, and worst of all, TP53, tend to have a much shorter duration of response, survival of 12 months or lower. So I think here I would probably consider one of the regimens that we have pioneered now, published from MD Anderson, also being done by Polish group and others, looking at cladribine in combination with low-dose Ara-C venetoclax. And the low-dose Ara-C component here may be especially important because Ara-C works quite well for RAS mutations, and you have shown a lot of this data where the response rates and outcomes, especially in this 60 to 75 population, are quite good and better than what has been achieved with aza-ven. So that's what I would look at.
Exactly. So these are the nuances that we're trying to bring up. This person certainly could HMA-ven, but it may not be the optimal therapy. As Dr. Dover pointed out, there are a subtype of AMLs, monocytic, most likely M5, M4, M5, who have RAS mutations, signaling mutations in KRAS and NRAS, which may not be the optimal therapy, which may not optimally respond to HMA venetoclax. There's work, as he said, by Colorado suggesting that nucleoside analogs such as cladribine may be very effective against these monoblastic or monocytic stem cells, and they may be more active. And I'll show you some data about our own experience with cladribine, low-dose cytarabine, and venetoclax, still a low-intensity regimen that are given to patients with a median age of 69, demonstrating a CR rate of 85%, MRD negative 79%, and a 2-year survival of 60% in this patient population. So moving away from HMA-ven, still using the power of venetoclax as a BCL2 inhibitor, but altering the backbone a little bit, maybe making it a little bit more intense, adding cytarabine, adding a nucleoside analog such as cladribine, which may be more active in this patient population. All right, here's another curveball, Dr. Dauber. Drop his age. He's 44 years old. He's fit. He plays tennis. Okay, he doesn't have hypertension, diabetes, or coronary artery disease, and he's a diploid karyotype. I know it says 7q there, but he's diploid. I'm going to tell you he's diploid, Dr. Dauber. His white count's elevated. He's still M5. He has an NPM1 mutation, okay? Does that mean anything? NPM1, what does that mean?
Yeah, so this is a very interesting case and tricky case. So NPM1 in general have a favorable response to cytarabine-based therapy, but there are many things that actually work well in NPM1 mutated. So these include gemtuzumab, these include pure analogs. If they have a co-occurring FLT3, then FLT3 inhibitors. So I think this patient has a high potential for curative outcome, and I would be looking at an intensive chemo-based regimen, and ideally I would be considering addition of venetoclax based on some of the emerging data with CLIA or FLAG-IDA-VEN showing very good outcomes here.
Exactly. That's exactly what I was thinking. This is a young patient who's fit, ignore the comorbidities, with a diploid karyotype, NPM1 mutated, FLT3 ITD negative. This falls at the ELN favorable risk. This is somebody I would use intensive chemotherapy with a curative approach, following very closely NGS MRD with things like in vivo scribe or RTQ PCR to look for MRD negativity for NPM1 after 2 cycles. If negative, potentially this person can be cured with intensive chemotherapy alone. If positive, I may consider a stem cell transplant consultation. But again, the fact here is that these patients are highly sensitive to intensive chemotherapy, and now with the backbones that we've created with intensive chemotherapy and venetoclax, we're seeing response rates close to 90 to 95%, with 85% MRD patient population. But you'll see how the dosing is different of venetoclax. Not the 28-day dosing, but a much shorter pulse during the time of chemotherapy to maximize synergy, to get deeper MRD negative remissions and higher rates of stem cell transplantation in those patients who need it. So just some supporting evidence about the things that we told. We're trying to stay away from Kaplan-Meier curves and too many tables. We want to really discuss the cases with you. So the first patient, certainly a standard case, standard of care, HMA venetoclax, an ideal patient, supported by VLA. The 70-year-old, okay, the cladribine low cytarabine regimen, it's been published in JCO. We presented it at ASH recently, demonstrating a 2-year survival of 64% in older patients with a median age of 69 years, particularly active in those patients who are RAS mutated, who have a monocytic phenotype, and this again needs to be confirmed in randomized studies. And finally, many of you asked on the online questions about intensive chemotherapy backbones in AML with venetoclax, and I think this is going to be the future. I think that we have slowly and steadily studied these regimens, whether it be 5+2 with Andrew Way in Australia, 7+3 plus venetoclax, a study by the Chinese, as well as CLIA venetoclax and FLAG-IDA venetoclax, pioneered at MD Anderson, and then, again, confirmed by folks like Italians, which demonstrated really high response rates. So what is the goal of these high-intensity ven regimens? To make sure that you don't miss, to make sure that you're responding, that the person you're in front of you goes into complete remission, has an MRD negative remission, and if has intermediate or high risk, can get to stem cell transplant within 1 or 2 cycles of chemotherapy in an MRD negative state. Just a little bit of the data again on the left. This is a propensity score analysis that we did at MD Anderson, looking at our intensive chemotherapy, such as CLIA plus venetoclax or FLAG-IDA plus venetoclax, compared to those same regimens that we did several years before without those regimens. So same institution, same backbones, the only difference is the venetoclax. And among patients who had intermediate risk disease or adverse risk disease by ELN 2017, we saw a significant improvement in overall survival. Again, not a randomized trial, but a propensity score matching age, karyotype, molecular mutations in these patients showing a demonstrated overall survival. These patients had higher rates of MRD negative remission. More of these patients went to allogeneic stem cell transplantation, suggesting a movement over there. On the second half, you see work by Sylvie Freeman and the UK group. This is the UK AML 18 study, which actually showed that among patients who have favorable risk AML, whether it be core binding factor AML, NPM1 mutated FLT3 negative, or non-adverse risk, the addition of an additional dose of GO, so 2 doses of GO, may actually improve overall survival. So the theme is the same. Among those patients who are sensitive, someone who's NPM1 in the front line, give them a therapy that will get them the highest rate of cure, at least MRD negative CR, that they can get to a stem cell transplant if they have higher risk features otherwise. Okay, going back to the HMA venetoclax. So the VIALE-A, this is the study, this is the update. Significant improvement in overall survival, median around 14 months with HMA ven. But as we did the longer and longer follow-up, you see that the curves continue to come down. Right? This is not, we're not seeing a plateau. Why is that? Well, people looked at this and said, are there some subsets that benefit more from HMA venetoclax than others? And Donor did a fantastic job, and his work is on the left. Donor and colleagues looked at the patients who were treated with VIALE-A as well as the phase 1b study. They did a pooled analysis. They looked at all their mutations. They looked at a risk score. The risk score is very simple. People who either have a p53 mutation, have a KRAS or NRAS mutation or a FLT3 mutation. If they have a P53 mutation, they fall in that red curve. It's called lower benefit. If they have none of the mutations, they fall in the higher curve called the higher benefit. And if they have any either RAS or FLT3 mutation, they fall into the middle curve called the intermediate benefit. And these are all HMA event-treated patients, and what they demonstrated is that patients who have none of those mutations, no FLT3, no RAS, no P53, did the best with HMA venetoclax. Median survival 26.5 months. Those patients that P53 mutation, median survival 5 months. That's apparently what you get with HMA alone, folks. So no addition of benefit with the addition of ven in patients who have double hit P53 mutations. But even look at those patients who are in the middle, either RAS mutations or FLT3 ITD mutation, median survival 12 months. Not that great in a population that we see very frequently in this patient population. We took this same score on the right and applied it to our MD Anderson group of patients treated with HMA venetoclax. Indeed, we validated this score. These curves look almost identical in a completely different population of patients that did not overlap with VIALE-A or the phase 1b trial, suggesting that this is a score that we're using. So those RAS mutated patients, those are the ones who are the monocytic folks. The FLT3 ITD, Dr. Davar will tell you how to treat those in the next session. But really focusing who benefits from HIV-VN, well, maybe those patients who are non-P53, non-RAS FLT3 ITD. We need to consider and develop new therapies for those other patient populations to, again, improve their benefit in the tune of 26 or 27.5 months. Okay, this donor classification, the molecular prognostic risk score, which we validated, actually led to a new classification system. This is actually hot off the presses, Blood, August 2024, so just last month. So donor and colleagues did a nice letter, acknowledging that, hey guys, ELN 2022 was optimized for patients who were treated with intensive chemotherapy with 7 and 3. Okay, so you can't use things like the ELN adverse risk and consider these with HMA and venetoclax. And they went back and looked and actually cited many of the published literature, including their own, showing that indeed there are patients who really benefit from HMA and venetoclax who were previously considered adverse risk, including those patients who had spliceosome mutations or secondary type mutations who actually benefit from HMA and venetoclax as long as they don't have things like P53, RAS, or KRAS. As you can see here, this is the new one where the favorable folks are the NPM1, IDH1, IDH2. We know they respond better to venetoclax. Mutated DDX41, right? If you guys recall, DDX41 is the gene that's associated with hereditary predisposition to AML later in life or myelodysplastic syndrome. They actually do very well with HMA and venetoclax, whereas those in the intermediate include the activated signaling mutations such as RAS and FLT3 ITD. So just something to keep in mind that there are patients you can select even better to optimize how you use HMA and venetoclax. And now getting to the business of actually using HMA and venetoclax. The label says give 5-azacitidine, 75 milligrams per meter squared for 7 days with venetoclax at a target dose of 400 milligrams daily for 28 days. And we've known over and over again as we treat these patients that maybe you don't need 28 days. Again, I'm speaking off label, this is a CME talk, but many times we've realized that indeed 21 days of venetoclax during induction may actually be enough. We routinely perform bone marrows around day 21 to assess disease in the bone marrow. If there's no disease, if there's a hypocellular empty bone marrow at day 21, we stop venetoclax on day 21, allow the patient that last week to recover their counts, and they actually do very well, recover their counts and go into complete remission. And so this is what we advocate in many of our patient populations. And then when we combine our new drugs, things like FLT3 inhibitors or MEN inhibitors, we go even fewer because we know that there are overlapping toxicities where we need to balance the risk of benefit and toxicities. Both should start on the same day, on day 1. Make sure your white count is low enough when you start the HMA and venetoclax because you worry about things like tumor lysis syndrome. The label of venetoclax says make sure your white count is less than 25. We have a different practice. We say make sure it's less than 15, especially among those patients who are sensitive, those who are NPM1, IDH1, IDH2, who we know respond well to venetoclax. Get their white count down a little bit further. Give them a little bit more hydrea, maybe a touch of cytarabine. Get their white count down before you start the venetoclax to mitigate and lessen the risk of tumor lysis syndrome, which is real in acute myeloid leukemia, especially the sensitive subtype. Escalate the venetoclax dose ramp up, 100, 200, 400 on days 1, 2, and 3. Reduce for azoles. The FDA, the label recommends 70 milligrams of posaconazole, of venetoclax when given with posaconazole. We and others have shown PK studies that perhaps 50 milligrams is better. In fact, when you look at the VIALE-A study, they use 50 milligrams of venetoclax with posaconazole. So these are some of the nuances that we learn the more and more we treat our patients. While you're giving the therapy, support them with transfusions. People ask me, is HMA-VEN intensive chemotherapy? I'll say, well, it depends on what you mean. Right? It doesn't maybe give you the mucositis, the severe mucositis, the severe diarrhea, the hair loss that intensive chemotherapy does, but it sure is intense on your bone marrow, right? So it does cause significant myelosuppression. They'll need blood products. They'll need G-CSF, as Dr. Dauber pointed out. We did a recent study showing that there's no adverse effect of adding G-CSF to these patients when treated with HMA and venetoclax. And finally, the bone marrow, right? Do the bone marrow on day 21. If you're worried and you want to give, if they're a bit more frail, do it on day 14. If there's no disease, stop at day 14 with venetoclax. On subsequent cycles, we drop the venetoclax duration from 21 to 14 days, sometimes down to 7 days if they're MRD negative. So there is a bit of a tweaking that the more experience you have with these, you may be able to assess. In fact, there are studies now looking at 7 days of venetoclax with 7 days of AZA suggesting very similar outcomes. And there's now a randomized study looking at 14 versus 28 days run by Dr. Uma Barate, looking at that specific question. Do you really need 28 days of venetoclax? And hopefully that'll show us or help us change our practice in the future in this patient. And if they fail after 2 or 3 cycles, I think that they're probably failing and consider alternative therapy at that time. Just another study talking about ven dosing and efficacy. This was done by Keith Pratt, and it's going from the top down. 185 patients were treated with HMA and ven. 24 patients had no cytopenias, but there were a bunch of patients, 161 patients, who had grade 4 cytopenia after achieving CR/CRh. And so what they did is half those patients, or 59 of those patients, they said, okay, let's drop your venetoclax from 28 days to 21 days right away, starting cycle 2. The rest of the patients, they continued on 28 days of venetoclax, and later on at some point when they became really cytopenic, that's when they changed their venetoclax from 28 days to 21 days. And what he showed here, you can see the overlapping survival curves, there was no difference. There's no adverse effect of dropping the venetoclax to 21 days, starting with cycle 2 because of the grade 4 cytopenia they experienced, and potentially may have improved the risk of death or toxicity from excessive myelosuppression. This is the French study that I just alluded to, the 7 and 7, 7 days of ven, 7 days of AZA, with a median survival of 12.8 months, and eventually a cumulative CR/CR rate of 68%, which is basically what you see with HMA ven in the VIALE-A experience. And I'll end with this, just a smattering or a summary of all of the different backbones that we're considering now with venetoclax with intensive chemotherapy, CLIA, FLAG-IDA, ven. You can see on the days of ven, only 7 days of venetoclax overlapping the chemotherapy itself, giving them 21 days or so to allow count recovery with the use of G-CSF with both of these regimens. The Italian group has started with 20 days. They're also coming down to 14 days. And you can see the Australian group started with venetoclax, gave chemotherapy, and then 7 more days. So, there's really a lot of research being done, a lot of tweaking, optimization. There are phase 2 trials, phase 1 trials now studying this. Eventually, as we get more and more patients and more excitement about intensive chemotherapy in the front line, I think that we'll move to a more optimized regimen. So I'll stop there, and I'll hand it back to Dr. Dauber. Before I go, to reassess your skills in customizing therapy and venetoclax regimens, after this particular section, how do you feel about your confidence about doing this? So go ahead and get on the QR code and answer the question.
I don't know if they're serving the wine. That would give people liquid confidence. That might help. Okay, so looks like modest to good, which is kind of, I think, where things are right now at venetoclax. We're still all learning anyways, so great. So I'm going to be talking about FLT3 mutated AML, where things have changed quite a bit in the last just 6 or 7 years. So let's take a patient example as we did with the previous session, and I'm going to ask Dr. Kadia for his thoughts. So this is a 67-year-old, and we kind of chose that on purpose. That's a common age for AML. It's also the age where we start having that discussion about fit versus not fit for intensive chemo options. So the patient comes here with fatigue, headache, dyspnea. White count is high. You see that high white count, you're probably starting to think this may be a FLT3 or RAS. They often present with proliferative disease. Cytopenias, creatinine, a little bit high, not bad, but it is a little bit high. And then the patient has a lot of blast in the bone marrow, which again is something that we see quite typically with FLT3. You get the molecular results, you've started hydroxyurea, patient is admitted, white count is coming down, and now 4, 5, 6, 7 days later, you see FLT3 ITD, NPM1, DNMT3A, quite a common triad that we see in our clinical practice. So I'm going to now ask Dr. Kadia firstly, what would he think of as the best frontline therapy for this patient? And where does he think stem cell transplant will come into play, or will it not for this patient?
Sure, thanks. So I think, 67-year-old man, certainly I've had to assess his overall fitness, his risk, his comorbidities. But if he is relatively fit enough, I think that the frontline approach to me would be intensive chemotherapy with a FLT3 inhibitor. He has FLT3 ITD. Options for me in the frontline include quizartinib. Certainly midostaurin is also a frontline option, but I think the potency of quizartinib, the recent quasar data, I think that quantum data, I would probably consider chemotherapy with quizartinib in the front line. I notice his creatinine's a little elevated, his white count's higher. I probably want to get that down, make sure he's not having TLS before I move forward. But if he's unfit, which I don't think he can tolerate an anthracycline-based chemotherapy, whether it be cytarabine or otherwise, I may consider, for example, an HMA-VEN plus FLT3 inhibitor-based triplet on a clinical trial. And certainly, I think as someone like this, high white count, otherwise fit, FLT3 ITD mutated, I would consider him for allogeneic stem cell transplant in first complete remission.
Yeah, no, that's great. And I think that's exactly the kind of discussion that's happening pretty much every week or more frequently in our clinics is how do you determine fitness of the patient? And is it really that we should give intensive chemo because we can give intensive chemo, or should it be the other way around, that we should only give intensive chemo when we really think it's going to be better than a low intensity therapy option, right? And I think that's where the train is moving to the reverse, where instead of saying somebody's not fit for intensive chemo, we're starting to think more and more we have to think that they should really be a good candidate for intensive chemo. If not, if you have an equivalent lower intensity option, maybe that is the best thing for the patient. So the same patient now, we did proceed with treatment. He received induction and consolidation, which is currently the standard approach for patients up to 70, even 75, although I would say above 70, we almost never do intensive induction at MD Anderson. So this patient was 67, fit, got intensive induction, achieved remission, and very importantly, we now have ability, commercially this is available through labs such as in vivo Scribe to do MRD assessment, not by flow cytometry, that is not going to give you adequate confidence, sensitivity, specificity, but by using PCR NGS, which can go down to 10 raised to minus 6 levels. And this patient has achieved not just a CR, but a 10 raised to minus 6 level clearance of FLT3 PCR. So now the question is, what do you do for this patient? Does this change your trajectory? Do you still go ahead and transplant this patient?
Yeah.
Do you consider not transplanting and do maintenance? Do you consider maintenance post-transplant? So, yeah, Dr. Kadia.
Absolutely. So I think, really challenging case, and we see this all the time, right? For those who are fortunate enough to have MRD negativity or PCR NGS at a very high sensitivity, it gives you the ability to really look, especially after 2 cycles, which is the prognostic sort of time point that I would consider. Look, he did really well with intensive chemotherapy with, let's say, quizartinib after 2 cycles. This is a debate and a discussion that I have with the patient. Certainly, as a sort of a baseline, yes, I probably would consider transplant in the first line, but now there is an option because he has achieved such a nice remission, such a deep remission that maybe we can get away without allogeneic stem cell transplantation. Maybe he doesn't have the perfect donor, maybe it's an unrelated donor, maybe it's a mismatch, maybe it's a haplo. Do we really want to do the toxicity of stem cell transplantation when I can give something else? For example, as the Quantum First trial showed, you can actually continue quizartinib as a single agent in patients who don't receive transplant and still significantly improve their overall survival. So I think this is a really interesting, kind of case because this is the kind of debates we have, and this is a discussion that I have with the patient. You have a sibling donor who's great, you're in great shape, go ahead and get the transplant, we'll give you some post-transplant maintenance. But look, if there's any issues, I may consider just giving them quizartinib maintenance after induction and consolidation.
Yeah. So I think this is kind of a moving target. I think today, as Dr. Kadia is saying, we generally are tending towards thinking of transplant in CR1 for our FLT3 mutated. That's what we've been doing for the last 20 years. However, some of these very powerful MRD assays like clonoSEQ in ALL are now giving us data that I will review that may suggest this may not absolutely be needed, especially in those borderline cases who are older, have organ damage, or may not have a good donor. So I think this is kind of where we have to start thinking and making those decisions as we get more and more data. So this patient has these options, so 67-year-old FLT3 intensive chemotherapy or potentially a triplet option. Here what you see is that because the patient has FLT3, the NPM1 is no longer favorable. It's important to note that. And this patient, if received intensive chemo, I also would probably do this with quizartinib, which has shown very good potency. The second generation FLT3 inhibitor preclinically is much more potent and has much better single agent activity than midostaurin. Now, I think my threshold to consider somebody not fit for intensive chemo today is very different from 8 to 10 years ago. So because when you had just HMA, AZA alone, response rates were 20%, so I really wanted to go for the 70-80% response, I would push 70-year-old, 71-year-old, 72-year-old. That's what we all did. Today, with HMA-VEN already, we're at 70%. With the triplet, we're at 90%. So I don't feel the pressure to take a 67-year-old, who may have some organ dysfunction, who may be a little bit weak, who may have had a recent complication. I would be comfortable to move on to a triplet with the emerging data. And then maintenance here, I think, is something that should be done, whether the patient goes to transplant or not. We are using molecular MRD-based assay in that setting. So if a patient does not go to transplant, for sure we will keep them on maintenance, as was done with the Quantum First study. They get 3 years of quizartinib, single-agent maintenance after induction consolidation. If the patient goes to transplant, then you can use, again, this molecular MRD, PCR, NGS, pre and post-transplant. If they were truly negative, both pre and immediately post-transplant, that patient actually may not need maintenance, and you may be done with the transplant based on the data from the Morpho study published in JCO. So let's look at some of these data very quickly. Quizartinib Quantum First, I think most of you are familiar. This slide has been shown dozens of times, published in Lancet. Here, addition of quizartinib to intensive chemotherapy improved overall survival. This was 18 to 75 years of age, and you can see that the benefit was quite clear, doubling of the median overall survival, as well as about 11 to 12% absolute survival difference, which is clinically as well as, of course, statistically met meaningful endpoint. That being said, when you look at where the outcome was really benefited, it is quite different among younger patients and older patients. The patients below 60 are really the ones where addition of quizartinib to intensive chemotherapy seems to have the most striking clinical benefit. Now, the statisticians who review this, or if any of you are in the room, will probably say, yeah, but this is not a fair way to do a comparison because it was not powered this way. That is true, but at the end of the day, we have to use the data we have to make clinical judgments because it's unlikely there will be separate randomized studies for younger and older. Based on this, many of us are very confident and comfortable using quizartinib in younger patients. However, for older patients, especially with comorbidities, other issues, we don't know if there's a huge benefit of doing intensive chemo quiz. Here, some of the HMA-VEN or HMA-VEN plus FLT3 may be a good emerging option or alternative. Again, I just want to highlight that MRD here, we're not talking about flow. We get a lot of emails every week from many different parts of US and outside the US where they say, oh, we saw this paper showing that MRD negative NPM1 or MRD negative FLT3 may not need transplant in CR1, but this is not with flow. Flow does not have the high level sensory specificity. I would not use flow to make any determination about transplant or maintenance. So I think that has to be really, really clear. If one is going to do this, it has to be done using this very sensitive, similar to clonoSEQ in ALL, PCR NGS. It is commercially available. It is covered by insurance. It is on the NCCN guidelines. The entity that does it is called In Vivo Scribe. So this can be ordered, and I know many colleagues across the US are sending it. And we're starting to see some data that helps us understand why some of the FLT3 inhibitors may be improving outcome. So this is looking at the Quantum First. This was presented by Dr. Sasha Pearl at the ASH meeting 8-9 months ago. And what they showed was that every time point, so after induction, after 2 consolidations, after 4 consolidations, there was a deeper FLT3 specific molecular MRD clearance with the use of quizartinib, 22 versus 11%, all the way at the end to 56 versus 41%. So about a 15% higher molecular MRD clearance, which probably is one of the key reasons for the survival advantage with quizartinib in the frontline setting when added to intensive chemo. Now, this paper, I think, is gained a lot of discussion, and I think is a very, very important paper, but there's a couple of things. So one, this is a retrospective study. Second, this study was based prior to use of FLT3 inhibitors. So we have to take it with a little bit of a pinch of salt, but I think conceptually this is probably in the right direction. So what they looked at, this was from the UK MRC, Dr. Othman and colleagues, is they looked at NPM1 MRD. They use a similar high sensitivity assay called RT-qPCR, which can go down to 10 raised to minus 5. And they said after 2 cycles of intensive induction, anthracycline daunorubicin based, if you achieved the molecular NPM1 MRD clearance, did those patients benefit from transplant or not? And what they show on the right side where you see the box is those patients who after 2 cycles of intensive chemotherapy had NPM1 undetectable at a 10 raised to minus 5 level did not seem to have a benefit of transplant in CR1. So you may be able to just monitor those patients, complete the consolidation, do maintenance, do every 3 to 4 month monitoring of the molecular NPM1 MRD, and you may have as good as an outcome without the cost, expense, toxicities of transplant. If there was any molecular MRD positive after those 2 cycles of intensive chemo, overall the outcomes are poor because this is a patient who is not clearing his MRD rapidly, but their CR1 allotransplant is very much indicated. So this is the first such data set. There are others being analyzed. We will be looking at our data as well, but I think that this may actually give us a strong group of patients where we may not need to go for allotransplant absolutely in CR1. Now, what about the triplet data? So this is something we at MD Anderson have been doing. It's not just with FLT3. We have HMA-VEN with IDH, HMA-VEN with menin inhibitors, other combinations. And of course, this is quite logical because as Dr. Kadia showed, with HMA-VEN, the survival in FLT3 ITD mutated patients was actually only 10 to 11 months. This is published by Marina Konopleva in Clinical Cancer Research a couple of years ago. So even though you get responses, these are short-lived. 11 months is really barely better than AZA alone, so we wanted to improve on that, and one of the approaches, as has been done in multiple myeloma, ALL, is to add an effective targeted therapy, but when you do that, you have to optimally dose reduce the components so you do not get severe myelosuppression. So this is something we have been doing over the last few years. We have now optimized the dosing regimen with only 14 days of venetoclax, which is probably enough based on some of the data from France where they're only using 7 days and 14 days of the FLT3 inhibitor. And with that, we are seeing very high response rates, true CR rates above 90%. And as you can see, the overall survival, remember these are older patients, not candidates for intensive chemotherapy, at 18 months, almost 60 to 70% alive. If you look at the Viale data at 18 months, this was about 25%. So this really to us looks like it will be a new way to treat these patients effectively. Of course, there will always be outliers, patients above 80, 85, where you cannot do the triplet, so you have to use the regimens wisely. But for the majority older patients, this is where we think the treatment will go. Now, maintenance, I think, has become, over the last just 5 to 6 years, a real standard approach within AML treatment, whether it's post-intensive induction consolidation or especially for FLT3 post-transplant. This is what the NCCN says. As you can see, clearly post-allotransplant in patient with a known FLT3 ITD, there is a recommendation to consider maintenance either with sorafenib, midostaurin, gilteritinib, or quizartinib. And in patients who are not able to proceed to allogenic transplant for some reason or the other, there is, based on the Quantum First recommendation, to do quizartinib maintenance. This is actually part of the FDA label for quizartinib and should be covered by insurance. So there should not be any scenario where we have a FLT3 ITD mutated patient who is not going to transplant, who does not get maintenance. I think that is a group we should definitely be doing maintenance. Now, post-transplant, whether we need maintenance or not, I'll show you some of the data that may help guide us. So this is just showing the patients who went to transplant versus those who were not able to proceed to transplant in CR1 in the Quantum First study. What you can see is that transplant is very important and very effective. So if you're looking for the highest curative outcome, you want to transplant these patients in CR1. That is still, in general, what we are doing. If we have the molecular MRD, then we may use that, but if I don't, then in general, I want to transplant patients CR1. You can see there with quizartinib transplant in CR1, you have a 75-80% survival at 3 years, which is great. But there are patients who cannot go to transplant at the end of the day because of logistics, finances, donor, patient preference, toxicities making them too weak for transplant. In that scenario, we do see that patients who continue maintenance with quizartinib still have a survival benefit. So if a patient cannot go to transplant after all the efforts, let's make sure we continue the quizartinib there so they can still have a reasonable survival. Now, what about maintenance in patients who go to transplant? So this study was a very important study. The primary endpoint of the study was actually to show whether gilteritinib as a maintenance post-transplant improved survival across the board in all FLT3 mutated patients going to transplant. Primary endpoint was not met. However, the very nice thing about the study is that it had sequential molecular 10⁻⁻⁶ MRD assay. And we found for those patients who had any molecular MRD pre or post-transplant at any level 10⁻⁶ or higher, there was a clear benefit of maintenance. So this is something we're applying in practice. We do bone marrow before transplant, bone marrow after transplant. If we find any detectable molecular MRD, we say this patient is going to have high risk of relapse. We're going to give them gilteritinib. That will improve their relapse-free survival about 15 to 20%, as you see it there. If you don't have access to that assay, I think at this point the only thing one can do is take the conservative approach and give the gilteritinib so that the patient does not have a high relapse risk. But hopefully we will all start using these molecular MRD assays more and more. So at the end of the day, we have multiple FLT3 inhibitors. We may have more in the future. There are ongoing trials looking at some of the newer ones that may have unique efficacies, and there are differences in the toxicity profile, so you have to be aware of these. Midostaurin has a lot of taste and nausea, GI issues. Patients often don't like it. It's one of the reasons we've moved to quizartinib. Quizartinib, you have to be aware of the QT prolongation, avoid concomitant QT prolonging medications, and this is quite doable, but one has to be aware of it. Gilteritinib does have some GI issues and myalgias, but again is quite manageable. So with that, we will go to the polling question. So let's think of that similar patient, 67-year-old, FLT3-ITD NPM1, received induction consolidation with quizartinib-based induction, and the patient is now in CR1 with testing showing an MRD negative remission. Let's be specific here, with a molecular PCR NGS. So what would you recommend today if you were able to get all of this data as a next step for this patient? Proceed to transplant, no maintenance. Proceed to transplant, gilteritinib maintenance, no transplant, but quizartinib maintenance for 3 years, no transplant, midostaurin maintenance, I'm not sure. So choose, and there's actually probably no absolute right answer here yet, so. Okay, so proceed to transplant, no maintenance. I think that's very much as a standard approach today. Morpho study would suggest that. No transplant, quizartinib maintenance, emerging data may be a good option. Proceed to transplant, gilteritinib maintenance, still reasonable, although maybe based on Morpho, I would consider that less. So as you can see, there's not going to be an absolute consensus, but we're learning more and more about these patients. So next slide, please. Oh. 67-year-old FLT3, okay, ITD and NPM1 AML CR1 after FLT3 induction. Now this patient is actually molecular MRD positive. So what would you do next? So that patient was MRD negative molecular, so we could do transplant sparing approaches and maybe avoid maintenance, but now he's positive. How would you change it? Proceed to transplant, no maintenance. Proceed to transplant with maintenance. Proceed to transplant with quizartinib maintenance. Proceed to transplant with midostaurin maintenance, not sure. Okay. Yes, so proceed to transplant quizartinib maintenance I think is very reasonable as part of the quantum first. Proceed to transplant gilteritinib maintenance also is reasonable. So yeah, these are the options. So let's move to the next slide, please. All right, so to close it out, I'm going to turn it back here to Dr. Kadia to talk about some of the new, exciting, emerging targeted therapies in relapsed AML.
All right, thank you, Dr. Dover. All right, folks, we're almost done here. We've talked a lot about standard of care. We talked about HMA-VEN. We talked about FLT3 inhibitors. We're going to move into a section now. We're going to talk about new innovative therapies, focusing on menin inhibitors, which you've probably heard a lot more about if you went to the AML sessions. Again, a highlights, sort of Cliff Notes version to really get you about sort of focus on what we're looking for with these new menin inhibitors, and hopefully we'll see some approval. So we'll start again with the case. In fact, the same case. It's still Stephen, still 67 years old, newly diagnosed AML, had FLT3-ITD, went into induction, consolidation with FLT3 inhibitor, whether it be quiz or gilteritinib, went to CR1, MRD negative, went on to FLT3 inhibitor-based maintenance therapy, did not get stem cell transplantation. 6 months, 8 months, 9 months, 10 months, he relapses. However, he is FLT3-ITD negative, which is actually not an uncommon finding. 40 to 50% of patients with FLT3-ITD mutated AML may relapse without a FLT3-ITD mutation at the time of relapse, so-called losing their FLT3-ITD mutation. And so now the NPM1 mutation is still there. People say this is an ancestral, very early mutation, probably the originating mutation of many AMLs that are NPM1 mutated. That's still present, but the FLT3-ITD clone has been sufficiently eradicated with chemotherapy and TKI, but he's NPM1 mutated. So now what? So he's the same patient. He's NPM1 mutated, so he's favorable risk, right? NPM1 mutated, FLT3 negative, right? Favorable? No? Dr. Dover, is that favorable?
No.
Why not?
This patient with the FLT3 mutation, so that kind of makes the patient higher risk.
And he's relapsed, right?
Yep.
So in the relapse and refractory setting, NPM1 no longer is a favorable setting. And there's some data that will show you that Dr. Issa and Dr. Dover actually published looking at NPM1 mutated FLT3 negative is favorable in the front line. But once you relapse, you'll see that they're not so favorable. Would you consider venetoclax here now in the relapse and refractory setting?
Yeah, so in that same paper, as you mentioned, where we showed that any relapse NPM1 has the same outcome as any relapse other non-NPM1, one of the groups that does really well is venetoclax-based therapy, especially if they didn't get into the frontline setting. So I would look for a venetoclax-based combination here. Yep.
Right, now this person received intensive chemo plus TKI, did not receive venetoclax-based therapy. Certainly, that would be an ideal patient where I would consider using ven in the relapse refractory setting, not label, but certainly in the guidelines. But if they had received a venetoclax-based regimen, then you got to really start thinking about what we can use in this patient population. Okay, so this patient, who let's say had been received ven in the front line, is there a potential for using things like MEN inhibitors, Dr. Dauber, in this setting in a clinical trial and novel combination settings?
Absolutely. I think that would be the first thing we're thinking about in a relapse patient with either NPM1, KMT2A, or the menin, MEIS1 overexpressing leukemias. And I think that's where the data is showing very exciting response rates, but not just as a single agent. I would really be thinking about a combination with the menin inhibitor and potentially a ven.
Well, I'm glad you said that because we're going to talk about that later today. But it just shows you how we sort of analyze each case in the journey that the patient has had. If they've had intensive chemotherapy, TKI, no venetoclax, the NPM1 mutated, they may still be sensitive to venetoclax, they've never had it. The person who had HMA ven, TKI is a triplet, maybe not so sensitive. This would be an ideal candidate for an optional or investigational clinical trial. MEN inhibitors really fit the bill, and we'll show you what I mean in NPM1 mutated AML. So just as a summary, we have a patient who has lost FLT3 ITD mutation at a very high sensitivity assay. His NPM1 mutated is relapsed, loss of FLT3, did not have venetoclax up front, maybe considered a ven-based strategy. If they've had ven-based up front, in the future consider a menin inhibitor-based strategy, and there are several options to choose from, hopefully, in the near future. This is the study that I was referring to, a very important study looking at the outcomes of patients with NPM1 mutated AML in the relapse setting. We know frontline NPM1 mutated, FLT3 ITD negative, they are favorable. When you relapse, that is not the case. So you can see there that whether you have NPM1 mutated or not, the outcomes are actually the same if you're in the salvage setting. Look at the different salvage. Salvage 1, 7.8 versus 6 months. Really doesn't look very favorable to me. Salvage 2, certainly not. And salvage 3, 3.5 or 3.6 months, essentially the same. So once you relapse, all bets are off the board. But among those patients who had relapse disease, who had NPM1 mutated, the survival was improved with the addition of a venetoclax-based regimen rather than a non-venetoclax-based regimen, particularly if they had not previous venetoclax, suggesting that there's a role for that in combination strategies, again, off-label in the relapse and refractory setting. As we are about to sort of embark on talking briefly about the MEN inhibitors, I want to briefly remind you of KMT2A. KMT2A is the gene, also previously referred to as MLL, the MLL rearranged AMLs. That gene is located in 11q23. It's called KMT2A, it's the same gene. And so KMT2 rearranged AMLs are not very common, but they are a significant concern and a comorbid or morbid concern in patients with acute myeloid leukemia, but also with ALL. KMT2A rearranged leukemia happens in pediatric ALL, in adult ALL, in adult AML, in mixed lineage. A lot of times you'll see patients with sort of B-cell markers and myeloid markers. Often these are sort of bilineage or bilineal. They have MLL rearrangement. Sometimes you can treat one and they relapse with a different phenotype. So it is a difficult disease. The response rates to frontline chemotherapy are not bad. They're in the range of 70%. It's the fact that they all relapse all the time, and their overall survival long-term is very low, with a 5-year survival less than 25%, even in young, healthy adults, despite allogeneic stem cell transplantation. We have a plethora of new MEN inhibitors in development, starting with the top, the most sort of further along, revumenib, made by the Syndax company, ziftomenib by Cura, J&J, now called bleximenib. There's also one by Sumitomo, DSP, BMF, and then finally Daiichi has a small one that I think has stopped development. You can see on the right that there are essentially two major structural types, the so-called phenopyrimidine and the benzamidine, where there's a moiety that seems to target certain pockets within the menin protein. And there's certain implications which we'll find in the future where certain may be more effective against certain mutations versus not, but that biology really needs to be borne out before we can make any definitive things. But these are the range of the different menin inhibitors that we have available, with revumenib probably furthest along in the development and hopefully close to some regulatory discussion. We'll talk a little bit about the studies. I'll be very brief. I promise I won't go too into the data because I think that really puts people to sleep at 8 p.m. at night. But basically, what you'll see here is very important, right? So revumenib as a single agent, no chemotherapy in patients with relapsed and refractory KMT2 arranged AML, or NPM1 mutated AML. They were a mixed bag. Again, median survival, we're talking about 3 to 6 months. Poor outcomes. Their response rate, CR rate was 30%, overall response rate of 53%. So CR/CRh at 30%, overall response rate of 55%. I want you to remember those two numbers because as we go through different menin inhibitors, it's sort of a repeat kind of, sort of a very similar finding. CR/CRi rate around 35 to 40%, overall response rate, which includes MLFS, around 50 to 55%. It's a common theme. Duration of remission, 9.1 months. Certainly not bad for relapsed refractory setting. Better if you go to allogeneic stem cell transplant, which these drugs allow you to deliver these patients, and that is the key. They get you into remission. It's a biologically active agent. It causes differentiation syndrome, particularly in patients who have KMT2A rearranged AML, more than NPM1, and they can get you to allogeneic stem cell transplant in remission with very few side effects. There's also a phase 2 study of the revumenib, which was recently published in JCO by my colleague, Dr. Gus Issa. This study has 2 arms, the KMT2 arranged AML, showing again a high response rate, 63% overall response rate, which includes things like CR/CRi, MLFS. And then this data, along with the early data, is being put forward now to the FDA for consideration of regulatory approval in patients with KMT2 rearranged acute myelogenous leukemia. There's a second arm in there of NPM1 mutated AML that is not yet read out, and hopefully we'll see some data from that coming up soon. The second menin inhibitor, ziftomenib, made by Cura, again, very similar responsive monotherapy. This company decided to focus a lot on NPM1 mutated AML, and you can see here, these are only NPM1 mutated AML. Among those patients, a CR rate, true CR rate of 35%, that's with count recovery, CRc or CR composite rate of 40%, and then overall response rate of 45%. So again, CR/CRi around 35 to 40%. Here, the overall response rate, 45%. You can see many of those CRs are long-lasting and durable, at least in the median follow-up that's seen in this study. But certainly an active drug as a single agent in a very difficult disease, which hopefully can then produce better outcomes. And you'll see in the combinations, really dramatic outcomes in this very high-risk patient population. And let's walk right into combination. So that, I mean, with any of these drugs in AML, certainly there's room for single-agent therapy. We often develop them initially as single agents to sort of watch the toxicity, differentiation syndrome, QT prolongation. But I think the real activity you see will be in the combination therapies, and those studies have already started. And I'll just give you a glimpse of some of them. So this is revumenib, the drug by Syndax, in combination with HMA venetoclax, a backbone that we're all familiar with, in patients with newly diagnosed AML who had either KMT2A rearrangement or NPM1 mutated. So newly diagnosed NPM1 mutated or KMT2A rearranged with HMA ven plus revumenib. And you can see the bottom line in the red in the right lower hand corner, CR/CRi rate of 96%, overall response rate 100%. 24 out of 24 patients with newly diagnosed AML with those particular gene abnormalities responded to HMA ven plus revumenib. Now, this is not the response rate of HMA ven. You said, well, it's just HMA ven. But we know that doesn't lead to 100% response rate. It's more in the range of 60%. So clearly, this is a very active agent in this particular patient. Again, small cohort, but we are still excited. And hopefully, with larger cohorts, more studies, we'll see better outcomes. There is a similar study done by my colleague, Dr. Gus Issa, called SAVE, which includes revumenib plus oral decitabine plus venetoclax in newly diagnosed patients. Again, similarly, it was presented at ASH, response rate overall 100%. All patients responding with this very difficult disease. So very, very much enthusiasm. Again, early on in development, not approved yet, but this is where we're looking at. This is the future, hopefully, for this really difficult subset of patients. Bleximenib, this is the J&J compound, again, as a single agent, Dr. Jabbour reported excellent outcomes, around response rate around 35 to 40%. And on the right upper hand corner, you see now some in combination with ven and aza and KMT2 rearranged and NPM1 mutated, response rates from 62 to 90% in this difficult subset of population. So we're seeing the same theme with these drugs which attack menin, which allow inhibition of menin, allow differentiation of these sort of very immature blasts into a more of a mature phenotype, and then treated with chemotherapy, HMA ven, which is very active in this subset. You can see that the safety profile was excellent, listed below, very well tolerated combination, and differentiation syndrome observed only in 3% of patients, which is fairly good. DSP 5336, this is another compound, another menin inhibitor. Again, like I said, a plethora of great inhibitors. This is a compound by Sumitomo. Overall response rate, again, 55 to 57%, CR/CRi rate of 24%, no DLTs, and no clinical severe DS, right? So now, as we treat more and more patients, we start to see, as we did in the CML TKIs, right, sort of a differentiation, whether it be toxicity, whether it be tolerability, whether it be different things like QT interval prolongation, rates of differentiation syndrome. Is one more potent for NPM1 mutated AML? Is one better for KMT2 rearranged AML? The biology is the same, so they likely work in both, but the more we treat patients, that we will see that, which is the best to be given with concomitant agents, things like azoles and things like that, which are common in AML therapy. On the bottom, you can see the response rates at the dose that is considered to be active, at the biologically active dose, which is 140 milligrams twice daily, much higher response rate. So the composite rate you see on the top is all patients, including those patients who are treated potentially at a suboptimal or lower dose. But at the 140 milligram twice daily dose, CR/CRi rates of 33% and overall response rate of 44% in NPM1, 67% in KMT2A for a composite of 57%. So a very active group of drugs, excitement coming with combinations with HMA-VEN, but there are other combinations, right? So they're being developed. Why do we need to stick to HMA-VEN backbones? Can we be a little bit more innovative? Lintuximab AC225 is a antibody drug conjugate where the drug is a radioisotope, actinium, which, as you know, is being developed in relapsed refractory AML. What if we were to use a non-chemotherapy-based approach in these patients where we use actinium plus a MEN inhibitor in those patients, not only who have NPM1 mutated, KMT2A range, but those who have HOX/MEIS upregulation? So we know that as a single agent, the response rate is around 65%, including MLFS, in this really difficult population. And there's now preclinical data combining MEN inhibitors plus lintuximab, actinium. And you can see that's the bottom line there, that's flat. Those AML cells are destroyed with lintuximab. Again, this is preclinical data in mice. We get excited and then we don't, but certainly very, very encouraging. And I'd rather see a flat line rather than any kind of growth with the combination therapy. So there's a lot of great combinations coming. Remember that patients with NPM1, about half of them have FLT3 mutations. Patients with KMT2A rearranged, 20 to 30% have FLT3 ITD mutations. What about menin inhibitors plus FLT3 inhibitor-based combinations? This is actually ongoing. There are 2 studies that are ongoing, including quizartinib and gilteritinib with various menin inhibitors in patients with relapsed refractory AML who have both NPM1 or KMT2A with a FLT3 mutation in that setting. And so I'll stop there, and I'm happy to have you take a look at your phones and potentially answer this question. So reconsider this case of a patient with relapsed refractory AML who presents with an NPM1 mutation. Assuming that these are available on clinical trials, how likely are you to consider using a MEN inhibitor-based strategy, including combinations, to manage this patient? And the key is why or why not, right? Are you still a little bit unsure? You think you would try the MEN inhibitors on a clinical trial? How would you proceed? So let's go ahead and answer these questions, and the music will start. All right. Likely, you'll use these drugs. Wonderful. Evidence appears promising. Very likely, evidence appears clearly supports MEN inhibitor-based strategies. I tend to agree with you guys. I think that we're all very excited. The more we learn about it, we're using these, and we see responses in patients who shouldn't be responding. It's really exciting to see that in the clinic. So I share your enthusiasm, and I'm sure Dr. Davar does as well. We'll move on now to some questions from the audience. Dr. Davar, you want us to get started, and we can answer those?
Let's do quickly a few questions. So first one I can take is flow MRD an adequate substitute or surrogate if we cannot access PCR? The answer is no. I mean, flow MRD is good not to have as knowledge, but I would not, and we have not in our practice used it for decisions such as transplant or no transplant or for maintenance or no maintenance. So the answer to that would be no. Let me ask this one to you, Dr. Kadia. What is your recommendation for repeat genomic assessment in AML? At diagnosis only, or should it also be done after progression, relapse more frequently?
Yeah, great question. So my approach to molecular testing, to all the kind of, at baseline, I do everything, cytogenetics, NGS sequencing. If we have RNA-seq for various fusion proteins, I do that all at baseline. I try to understand the characteristics of the AML and then choose therapy accordingly. As I'm proceeding with the patient, depending on what they have, I will try to assess MRD potentially after 2 cycles. MRD for NGS, for NPM1 will be NGS. FLT3 ITD will be NGS, both by in vivo scribe. For things like core binding factor, APL, I'll use RT-qPCR, where I can look at version 16 or 821 or 1517. For all others, I use flow cytometry for MRD. But at the time of progression or at the time of resistance, certainly I will recheck NGS, cytogenetics, and potentially even flow to see what has changed after the treatment, because things change, clones evolve, and treatment definitely needs to change.
Yeah. I think so. A couple of questions which are very similar. So, how often do you see clearance of driver mutations after appropriate upfront therapy in FLT3 mutated AML? And have you transplanted patients with FLT3 mutated AML who have only received a FLT3 inhibitor combo with no chemo? Are remissions deep enough? So, the overall clearance of FLT3 when you use very sensitive, the 10 raised to minus 6 molecular PCR NGS in the quantum first was about 60%, and actually in our AZA-VEN guild published in JCO by Dr. Short was about 65%. So about 60% will clear the FLT3 at a 10 raised to minus 6 high sensitivity. And basically the outcome is very similar post-transplant in our experience in patients who have received intensive chemo FLT3 or HMA-VEN FLT3. What really matters is the depth of response pre-transplant. A lot of people worry, does the PAT matter? But really most of the data suggesting is that achieving molecular clearance, however you get there, is what's most critical. It doesn't matter if it's with intensive chemo, HMA-VEN, HMA-VEN FLT3. Let me ask Dr. Kadia this one, practical important question. What is your recommendation for optimal duration of HMA-VEN therapy in older AML?
Great question, right? So do you keep giving HMA-VEN? That's what the guidelines are, right? So if you have a patient with newly diagnosed, older patient, do you give HMA-VEN continuously? So yeah, you do. A couple of caveats. If the patient is older, you're going to think about stem cell transplantation. I usually give a few cycles until they're ready for stem cell transplantation. If they're truly older, unfit, I give them therapies as long as they can tolerate it, usually up to a year. I often then along the way though, I drop the doses. And there's some questions here about how I drop the doses. So initially, and this is based on stuff that we've done with the cladribine low-dose venetoclax trial. Initial cycle 1, I usually give 21 days of venetoclax. If they're in remission, if they're MRD positive during cycle 2, I give them 14 days of venetoclax. If they're MRD negative, I give them 7 days going forward. As we move further along, you can also drop the number of days of azacitidine. We go from 7 days to 5 days of aza. We'll go from aza 75 per meter squared down to 50 per meter squared, and then we'll, again, match the venetoclax to the number of days of azacitidine. So when you do these dose modifications, when you give them, instead of every 4 weeks, give them every 5 or 6 weeks, you can actually allow these people to prolong in sort of a maintenance regimen. We published our maintenance paper recently with 50 per meter squared of AZA plus VEN for just 7 days, and these people got 24 months of therapy. So I think 1 to 2 years of therapy. There is data now, and actually the last ASH meeting was something called, I think it was Stop VEN, or I can't remember the name of the abstract, but essentially these are people who had been receiving venetoclax and stopped for whatever reason. They were sick, they didn't want venetoclax, they didn't want it anymore, they lost insurance, whatever the case may be, they stopped the venetoclax and HMA, and they looked at their outcomes. And in fact, they were not bad. Their outcomes were not so bad. And if people did relapse, some of them were able to be salvaged again with HMA venetoclax. Not a large fraction, but some of them were. So I think the optimal duration depends on the patient, but anywhere from 1 to 2 years with modifications of the dose to kind of get them on a maintenance regimen is probably appropriate.
Yeah, and there was actually a very interesting data from the same UK group using, again, molecular MRD for NPM1 FLT3 in the blood brief report, where they also showed that if you again achieved NPM1 clearance by it was the 4th or 5th cycle of HMA-VEN and stopped after about 8 to 10 months, there was about an 80% 3-year survival. So again, I think use of that molecular MRD may become more and more important. The question here is, should MRD-guided maintenance be standard of care in FLT3 mutated AML, or is it too soon? I personally think it's a little bit too soon. Again, we have to make sure people are getting access to that right high-sensitivity molecular MRD. We know from ALL that getting access to clonoSEQ took many, many years. So I wouldn't make these decisions on flow MRD, and I think it's reasonable to wait another year or so until more data sets come out before we shift our standard of care completely. Let me ask you, Dr. Kadia, data on menin inhibitors in NPM1 relapse refractory encouraging, but would there be any role for menin inhibitors in frontline setting given the already good prognostic impact of NPM1?
Fantastic question. Thank you for that, Dr. Davar. Yeah. So no, we don't know, right? Because you're right. Whoever asked that question is a very smart question. Because in the front line, especially with the new therapies we have with venetoclax and intensive chemotherapy, the response rates are 100%. Their long-term survival is 80, 90, 100% with these drugs. Is menin inhibitor going to add anything to that? Or more importantly, how do you show that? How do you show that in a randomized phase 3 trial that the addition of a menin inhibitor to whatever combination you have is going to improve overall survival? That's p-value significant. So that's a very difficult question. I think that the best place to actually look at this is in lower intensity therapy, because while HMA venetoclax has high response rates in the setting, there's still potentially a risk of relapse, and maybe there's not a high MRD negativity rate. So if we want to look at a place, I think looking at those folks who are lower intensity therapy with the addition of menin inhibitor may be a bit more active with 100% response rate, but you have to offset that with appropriate toxicity management. So it's a very good question. I don't know the answer, but certainly it's going to be interesting to find out.
Yeah, and then last quick questions I'll just do two. Do you need to use IDH inhibitor in patient co-occurring NPM1 IDH1-2 mutations? I think this is alluding to aza-ven. We don't know. We are looking at the triplet aza-ven IDH, but again, there the bar is quite high because aza-IDH is already giving us 29-month survival if you look at aza-ivositinib data, so we have to wait for more mature data. I think standard today would be aza-ivo for IDH1 or aza-ven for IDH2 patients. And then lastly, TP53, if this patient 76-year-old had TP53 mutated AML, what would you treat or change? Unfortunately, it wouldn't change what I did. I think HMA-ven is still reasonable. One could consider using HMA alone or starting with HMA-ven and then dropping to HMA alone. The reality is whatever you do, the survival is about 6 to 9 months. There's no magic thing we can do. TP53 is difficult and there's no effective therapy yet, but with a lot of ongoing efforts with cellular therapy, maybe in the future there will be. So with that, I'm going to stop. It's almost 9 o'clock. We're at time. You can definitely go get the slides if you'd like to look at them in more detail, as well as eventually the recording will be fully up. This will be at the peerreview.com/AMLHouston24 URL link. And other than that, thank you also very much for staying here late. You guys are extremely dedicated. Hopefully the dessert was worth it, and maybe the talk was as well. And have a good night. Take care. Bye.